Good morning, everyone. Today, I'm very blessed to be joined by Daniel Reese, who's the CEO of IntellaTriage. Daniel began his career as a U.S. Navy submarine officer, which I didn't know that until recently when I was doing my studies on him. So we're going to have a lot to talk about the Navy here. Learned a ton about Daniel as I've done research. He's married. He's got a family. He followed in his father's footsteps. So we're going to learn about that. But welcome to the podcast, Daniel.
Tom, thanks for having me, and I appreciate the introduction. Yeah, the Navy is not necessarily something I publicize a ton, but it was a great experience, that's for sure.
Yeah. So tell me how all that get started. So you were a Navy officer. You went to the Naval Academy. Is that right?
Yeah, I went to the Naval Academy right out of high school. My family has a pretty long tradition of military history, so I was I had a brother who did not join the military, and so I felt like I kind of needed to, but was really driven by the mission of armed services, and the Naval Academy was great. It was definitely a unique experience, not your standard college experience. Me and my wife trade stories all the time about how I didn't have a real college, but it was great, and then went straight into the active duty Navy after that and submarines.
Go Navy, beat Army. We all spend one day a year talking about that for sure. And have a bunch of my buddies that are Marines. Really involved in the Fold of Honor. And I don't know if you know Steve Pinniger, the CFO at St. Croix and president of St. Croix, does a big thing every year. It's called the Pinniger Open. But we always give a whole bunch of money to the Fold of Honor. And then actually, one of the kids that played football with Cole plays up in Minnesota, and he raises $1 per yard that he gains every year. He's giving away a ton of money to the Folds of Honor. So you went to the Naval Academy, then you went to submarine school down in, where was that? In
Charleston, yeah. So the
Charleston, yeah.
Naval Nuclear Power School down in Charleston. So moved down there right after graduation. Was there for about 2 years, and then there's a prototype down there as well. So we have most people don't know this, but there's two different places for prototype submarines, which is basically a nuclear reactor welded to the pier. One's in Sarasota, New York, and the other's in Charleston, South Carolina. And I stayed in Charleston for both. I mean, loved Charleston. It was a great time. Me and my wife loved it down there. So.
Yeah, Charleston's a cool city for sure. And then did you ever actually get to go out on the boat, or how long did you serve?
Yeah, so I was 4 years active duty. I did about 2 years of training and then 2 years attached to sub. And the last half of that, I actually went and worked at the sub school in Groton, Connecticut, which is where my sub was stationed. So I was stationed on the USS San Juan, met them out on deployment in the Middle East, and did a little bit of that deployment with them. So I had some underway time. It was a unique experience. My wife always tells me that it was, she's very glad she didn't get to see the sub until I got back, because submarines are as tight as you would think in your mind, maybe even a little tighter. So, but it was great. We had a blast on mission. We had a really good time.
Yeah, that's wild, man. I've been on one of those subs. I didn't serve on a sub, but I was on it. I'm like, nah, not for me. Can't do it. You guys are studs. I can't believe you did it. Well, cool. How did being on a submarine and being a Navy officer, how did that influence how you lead? And what did you learn from that? And then I want to talk a little bit about that transition, because when I got out of the Navy, I was like, holy crap, what am I going to do? And, I was really good at the Navy, but I didn't know what a civilian life was. And like you, I went, straight from high school into the Navy, and I didn't know I had skills at all. So how did that transition? And then what did you learn from that? And then what did you take away from the leadership side?
Yeah, on the leadership front, I mean, don't realize how many lessons you're getting delivered to you in the military just all the time. You're kind of subconsciously just always learning about leadership and understanding, here's what has been effective for me, or here's what I've seen be effective for other people. But I mean, even going back to the Naval Academy, you have a dedicated, 2 semesters of leadership class. You understand the frameworks and theories a little bit, then you get to try it out in the fleet. I think the biggest thing for me, and coming from the military and having led a team right into the private sector, was really talking about servant leadership. I mean, that was always the leadership style that resonated with me, and this is definitely a little bit more Marine Corps than Navy, but the leaders lead from the front. They're the last ones to eat. They're the first ones into the fight. That has always resonated really heavily with me, of really trying to deliver for my team, but showing them how to do it and helping them develop in that front, versus just, a kind of a dictator style leadership style that has never really resonated with me.
Yeah, that's cool. Have you ever listened to that admiral? He does a speech. I don't know where it was. It was at some college, and it's called Make Your Bed. It's a great speech. And ultimately, he's like, every day, just get up and make your bed. Do the first thing, get up and make your bed. But it's amazing when he talks about, what he learned in the military was the discipline of, making your bed. And people always talk to me about it. They're like, you still make your bed. My clothes are all still hung the same way. I still wear the same thing every day to the gym. It's all just ingrained into it. It's cool. So, all right. So walk me through. You're a naval officer, get out of the Navy. Of course, they hated that you got out, just like they hated that I got out. And now you got to make this transition. You got to find a job, right? And so, walk me through what were you doing then, and how did you get to IntellaTriage?
Yeah, I was fortunate. I had kind of a slow path out of the Navy, so went from the sub to a bit more of a desk job for my last 6 to 9 months, and that allowed me a little bit of time to just kind of survey the landscape a bit. Ended up applying to business school while I was still in the Navy. Got accepted to business school while I was still in the Navy, and as I was getting out, I had a gap between the Navy and business school, so I went and joined my family business. So another thing a lot of people don't know about me, my family has a family business based here in Nashville that's a little over 100 years old, and I would have been fourth generation in the business. So I went back there for 6 or 8 months, and really enjoyed working with my dad, my brother, cousin, and uncle, and then transitioned to business school, where I said, I need to learn the hard skills of business. I knew nothing about finance. I didn't know about a P&L or the tactics of marketing or any of that. So did all that, and then took a job right out at a private equity firm doing QSR, quick service restaurant roll up, and just did not like my job at all. Like I didn't realize how mission driven I was, how much I needed to believe in what the organization was doing to enjoy my job. And the guys I worked for were great, so they made it tolerable, but it was just one of those where I didn't get a lot of personal fulfillment doing. So at that point, this was mid 18, I decided to try to find a business to purchase and operate. Found a group of investors who were aligned with what I wanted to do. I knew I wanted it to be kind of a mission-driven organization, so really focused on healthcare. Around that same time, my dad was he was going through end-stage renal disease, so he was on dialysis. He had a lot of home health. We knew hospice was eventually going to be what happened. He did qualify for a kidney transplant. So there's a lot of things that we were going through, and I started learning about the industry. And then met the founder of IntellaTriage just coincidentally at a conference, and started talking to her about what her vision was and how she had built the business over the past 12 years. And we really hit it off and just really connected. She had another personal experience, which is why she founded IntellaTriage. And just kind of all things aligned for us to partner up and me to join the business and take over as CEO in 2019.
Wow, that's a cool story. And is your dad still with us, or did he pass?
Oh, he passed like 2 months after we acquired Tiller. So we acquired in November of 19, passed in March of 2020.
Well, I want you to get on my bandwagon. I have total respect for what you're doing, and I'm on this bandwagon, and I've talked about it on 3 or 4 of the podcasts. But some of the sickest, saddest patients that we see are home health patients that have end-stage renal disease. They have 10 other comorbidities. They have diabetic. They usually have CHF. Their organs are shutting down. And because no doctor will say stop dialysis, they don't get to go to hospice, and then they die on home health, and they don't get all the benefits of the hospice. And it just really perturbs me. And I don't understand why Dr. Oz and the government and Kennedy and HHS and all those guys haven't figured this out yet. But I know it's the dollars, and I know it's the money and all that kind of stuff, but it really bugs me. And I see these patients all the time, and it breaks my heart. And so kudos to you for being able to surround your dad with home health, and you can do home health and dialysis, but you can't do hospice and dialysis. And I don't understand. I mean, you can, but it has to be reimbursed in a different way in order to get people to use it. So
yeah, that was my dad. All the things that you said, CHF, diabetic, had all these other comorbidities that were, but he didn't want to go to hospice and stop dialysis. So that is one that we talked a lot about different hospice providers and as physicians. But I agree with you. It's one of those that really should be included in that hospice benefit and utilized.
Well, someday they're going to figure it out, because Medicare is spending, I mean, the patients that go on to Medicare hospice are the sickest of the sick, and they're spending all the money. And those patients that don't, they're still under Medicare Advantage, but then it's just, they're on dialysis, but they have all these other diseases, and it's not the right way to go. And so the government's got to figure it out at some point. But, I'm going to keep pushing it as hard as I can throughout my career. And, but I see them all the time. It's tough. All right. Talk to us about IntellaTriage. What do you do? Why is it? What was important to you about it? I know you say it's mission driven, but most people don't know what it is. Tell us about it.
Yeah, so IntellaTriage, I would say at the core of what we do is telephone nursing. So it's primarily after hours. Whenever I joined the business, it was essentially only hospice and essentially only after hours. We've definitely evolved the business since then. We do daytime, we do home health, PACE, palliative, we do kind of the full spectrum of post-acute. But at the end of the day, what we're doing is we're partnering with providers to provide, seamless care whenever their workforce is a little bit more underutilized. to be after hours. And, patient calls in, they get an IntellaTriage nurse. So we have what we call our nurse first model. We believe strongly that the best outcome for a patient and best support for the family is getting the patient or the family to a nurse as quickly as possible. And so it goes directly to a nurse on our team. We have access to all the chart, whether through integrations or just direct access through some kind of remote desktop. And, really it's focused on trying to fully triage the patient to understand what's going on, help the family understand, the disease progression and what's happening with the patient at that time, and providing emotional support. And then there's just, there's quite a few calls we can't resolve via the telephone. So that's when we work back with our customers whose providers are, have clinicians in the field who can go make home visits and provide that care in the home. But it's really to try to, have the most appropriate utilization of home visits versus always just having a nurse go to the home right away.
That's awesome. So if I just have a question about my medications, or, this medication is making me feel dizzy, or Nana's dehydrated, or Nana's lethargic, or whatever it is, the family member can pick up the phone, call 1-800, whatever that number is, to the agency. It'll ring in your phone. You have a nurse sitting somewhere in the United States or are they international, or are they only in the U.S.?
So there are a couple of key organizational decisions we made is, we wanted, quality is the biggest concern for us, right? So we want to make sure we have high quality nurses who are with the triage. So they're all U.S. based, all W-2 employees, so no 1099s. That really allows us to, dictate the training, dictate their schedules, and really have them invested in what we're doing. So yeah, it's all U.S. based.
Wow, that's it. So they're all. I thought they were all all 1099. They're all W-2. So that's cool.
Yeah, for us, they're all W-2s. It's one of those we tried 1099s back in the very early days of whenever I joined, and we had too many call outs, too many people be like, you put me on a schedule, but I'm not going to work today, and they own that as an independent contractor. So we just couldn't deliver the level of service that we felt was we wanted to benchmark ourselves on.
And so I'm a nurse in this community. Most people are probably ex home health or ex hospice nurses that are tired of going to see patients anymore. They don't want to be on a schedule anymore. They want to work at night. They want to have flexibility. They want to have freedom. So they apply for a job. You guys take them through a training program. Do they have to live in Nashville, or can they live anywhere?
No, they can live really compact states. A nurse that's a part of the compact licensure is the one requirement we have. Obviously, there's some requirements around the internet and all that good stuff. Yeah, most of our nurses are part-time, so a lot of them have full-time other jobs. They do this either, on the side or supplemental income, and then we supplement with full-time. Yeah, we take them through kind of our orientation process week one. We train them, kind of on the phone trainings weeks 2 through as much as 6 weeks, just depending on the need of the nurse. It's really teaching them that we hire experienced home health and hospice nurses. So really, we don't want to be teaching them home health and hospice. We can refine that, but what we really want to be doing is teaching them triage. There's a little bit of science and art to triage that we want them to kind of learn and be comfortable with, so they can deliver the most effective results for the family and the patient.
That's cool. That's real cool. All right, let's skip over to our industry, home health and hospice. What do you think is most broken in home health and hospice today? And I mean, how long have you been doing this? 4, 5, 8 years?
Yeah,
6 years. Yeah. So in the last 6 years, you've seen a lot of change. Well, what's mostly broken? What do you see that's mostly broken from your vantage point?
Yeah, I don't know if I'll say broken, but I think the one area that we see a lot of opportunity there's two areas really. One is interoperability, right? Just allowing the ecosystem to have more access to the information they need in order to provide proper care for the patient. You see a lot of, the EMRs, really making a lot of headway on this. But that's one as a third party vendor, right? If we don't have the best available information, we have to have workarounds to get the information. So interoperability is one that I just see in post acute a little bit further behind than acute care. I would say the second is how we think about the time of care, right? So many of the providers that we meet with initially really focus on the case management from an 8 to 5 perspective or 8 to 6 perspective. Us being obviously after hours focused is pretty salient for us, but there's a lot of opportunity to understand what happens from 5 p.m. until 8 a.m. and on the weekends to really improve the care delivery as a whole for a family or a patient. And it just seems to be very under indexed. So most providers don't know what kind of calls are getting after hours, how many calls are getting after hours, who's calling after hours at an institutional level, right? The field nurses probably know because they're going to make the visit, they're answering the calls, but at an institutional level to be able to really work on that care delivery model for a 24/7 experience versus just whenever everyone's working during Monday to Friday.
Yeah, it's interesting to me then, and being a guy that's I built a lot. So on your interoperability question, agree. I built a lot of those problems you have. So sorry about that.
The tech has changed so rapidly,
Oh, it has. Yeah, tech is changing fast, and and our interests are changing fast too. But on the 8x5, Monday through Friday kind of scenario, it's interesting because when most of the time when the family, and I've been in a lot of hospice scenarios, most of the time when the family is coming to see Nana or grandma or mom or dad, they work 8 to 5 or 9 to 6 or whatever. And so they're there after hours and they have a lot of questions like, what's going on with mom? What's going on? What'd the nurse say? I hear this all the time. What'd the nurse say? And when was the nurse here? And I don't remember. And what'd she say? Everything's fine. And they're like, mom, you're changing colors. You're in pain. You're struggling. You're breathing harder. And they want to answer those questions and like, what's going on? And there's nobody to call. If 8 to 5, you call and you get the answered service. And we all of us don't like talking to answering services. So I think the model's right. I think what you're doing is right.
That's exactly the founding story of IntellaTriage. So Susie was full-time, she had a full-time job. Both her grandparents were on hospice and she just could never connect with the nurses. So that's the founding story of IntellaTriage, what you just explained.
Right. And having access to that medical record is really important. Like, what are the meds? Who's the doctor? Where's the allergies? What are they eating? They not eating? They fall? They not fall? I mean, all those kind of things is all documented right there. But if you don't have access to it and in some way to quickly look at it and say, okay, I see you're on Coumadin and they drew a PTINR or whatever that is, you have this for pain meds. You can't swallow, you have a Macy cat, whatever it is. That all those things are super important to a clinician. And so without having that, how do you hand them off? I mean, if not, you're asking a whole lot of questions that nobody likes to ask, right? And so that's a real challenge. So staffing shortages are becoming a really big deal in our industry. Like if we could hire another 1,000 nurses, we'd probably all hire them. And so how do you recruit these, nurse angels that are answering the phones and dealing with this stuff? And I mean, what's your recruiting trick and how are you handling that?
Yeah, we are in a very fortunate position that I don't think I appreciated in the early stages of the business. In that, while there is definitely a nursing shortage, we are one of the more attractive options for nurses. So we consistently have thousands more applicants than we can hire because so many nurses want that
Really?
part-time work from home flexibility. I was telling someone this the other day, and we had, just over 30,000 applicants, qualified applicants last year for, 300 positions that we filled. So it's a great problem to have. I think for us, it's all about making sure we find the right nurses that have the right experience, have the right disposition for phone triage. It's not for everyone. So that's the challenge for us, is making sure we get the right nurses, train them appropriately, but actually just finding them. Fortunately, they're there for us when we go to look at our job postings.
Wow, that's pretty cool. I didn't realize that's awesome. I bet you a lot of other providers would love to have those 30,000 nurse applicants for sure.
Yes.
Yeah, that's really cool. A few more questions on the industry. Home health or hospice, which one? You guys are more dominant in hospice today because you started in hospice, or is that shifted?
Yeah, from a patient count perspective, it's about equal. So it's just over 30,000 patients on each service for us. From a call volume, hospice is definitely higher. And so, our hospice, the utilization after hours, we tend to look at calls per patient per week as kind of the utilization measure. So hospice is, anywhere between 50 and 60 calls per patient per week per 100 patients, I should say. And home health is more.
I was going, wow.
Yeah. 50 to 60 per 100 patients. And then on home health side, it's more like 5 to 15 per 100 patients. And so there's really different utilizations of the services. A patient count, it's about equal. We've definitely shifted more home health over the last few years. We've grown that a little bit quicker pace than the hospice, but we've also grown more on the hospice daytime than we probably have anywhere over the last 12 months, at least. That's been a big growth vector for us, is that hospice daytime triage care team coordination.
So it's 24 hours a day. You call this number, you get somebody on your team. It's going to help that patient, and then they're going to coordinate back to the nurse. Like if the nurse
Exactly.
or if the DME equipment quit working, the oxygen's low, I don't have enough supplies, all that kind of stuff. They're going to write notes and coordinate back to the EMR. That's cool.
Yeah,
Okay,
exactly.
that's awesome.
HCHB is proud to sponsor the Last Visit First podcast, which explores the complex issues faced by today's home health and hospice providers.
In the spotlight today, Chief Revenue Officer Hannah Pearson, explaining how HCHB uses technology to connect people.
One of my favorite phrases is relationship architect. The focus is about the client and building the right community, the right fabric of community around our customers, making sure that from the very bottom to the very top, they had a resource and a contact to reach out to with any problems, and that we could connect them quickly and expeditiously to the right resource. That's where the client success team was born, and we touch people at every level of the organization.
Where do you see home health and hospice care headed over the next 5 years? It's a tough question, I know.
Very tough question, just because I feel like there's so many things that are changing at the moment. I think there's a couple things. One is I do think we're going to continue to see a push for a little bit higher acuity patients in the home. We started kind of talking about that end-stage renal disease. I do think those kinds of patients are starting to gain a little bit more traction for not just in hospital care or hospital at home, but home health and hospice at the home. I think we'll see a little bit of shift to that. I don't know how this will happen, but I do think we'll continue to see the shift towards value-based care measures and reimbursement styles. I think that will be something that it won't just be about how many patients you have on census or billing by the type of patient you have, but it will actually be on the outcomes based, especially in the home health segment of the market. So I foresee that kind of continuing to shift. And then I think the biggest one that we're very cognizant of is just a little bit of like workforce redesign, I would call it. It's really the hospices are going to have, for hospice and home health, are really going to have to think about how they design their care teams to get leverage and make sure everyone's operating both at the top of their license and as efficiently as possible. Margin pressure is only going to continue to increase. The cost of labor is going to continue to increase and probably outpace. So if we don't figure out as an industry how to become a little bit more efficient, then it's going to be really tough to stay profitable in the industry. So I would imagine workforce redesign is a big one that I will see change, and it's one of the areas we're working with our providers on. And one of the reasons we've grown our care team coordination so much is because we're starting to deliver that daytime care that previously was a receptionist at the office working with the care team managers to execute on, and now we're able to deliver a little bit more of a coordinated care model. So those are the big changes I think I see.
Just to add to what you're saying, I mean, Medicare Advantage is continuing to gain popularity. So we're seeing more and more and more, elders take the Medicare Advantage model versus traditional Medicare model, especially on the home health side, not necessarily on the hospice side. So I think over the next 5 years, you'll continue to see that grow. I mean, we're in that business with Tango, and the crazy metrics are there. It's how fast can I get to your home and get you, settled in, and I look at the stats all the time. It's we have agencies that are, 4, 5, 6 days. Nana gets out of the hospital and it takes 4 days to get her admitted. I mean, you start thinking about Nana, over the last 4 days, what has she been doing for 4 days while you're trying to do paperwork and get authorization, all that. So we got to streamline all that, make it better. But I think you guys come into play there as well. I mean, how do we, outreach her when Nana has a question is super important. So yeah, that's cool. I also believe the hospice model is going to shape and change too. And the Oz came out with a report that, there's a whole bunch of fraud in California and Arizona and Texas and Florida. And there's fraud everywhere, but they're really going to scrutinize that. And the guys that are doing the right thing and providing the great quality of care and all that are going to be fine, but they're going to go through a little bit of pain here in the next couple of years. And I think they want to carve all this, fraud out of the system and make sure that all patients are appropriate. So good quality clinical documentation, good response is going to be really important. How has Hope changed your business? My guess is that the Hope measures in hospice has made it probably either increase your business or decrease it. I don't know, because we're doing more visits for patients that have pain and those kind of things. It's probably helping your business or helping the number of calls that you guys are managing, right?
Yeah, I think it's still early, but I do see kind of it being a tailwind for us. I think when you think about, hey, when a visit needs to be made for pain, for example, well, if you get that, if you get that at 9 p.m. and an answering service takes it, and then they message the nurse. That nurse may or may not go out and make a visit. And then it's really the next day that's even starting to be like, oh, this patient's in a lot of pain. We need to make sure we take action on that. And so, having that nurse first model where we can triage the patient, get the pain stabilized if they have available medication in the plan of care, but then make sure we're following the appropriate escalation pathways of, okay, this is an important one to be in the home end tonight, helping them prioritize that by reducing some of the other after hours volume, I think is where we're seeing the benefit and where most of our partners are really, pushing us to drive those escalation pathways a bit more.
Yeah, I mean, it's interesting. They implemented Hope, and the government's got all this reporting that supposedly is going to come out, but nobody's seen it yet. Nobody really knows what the reporting's going to look like. And so, I think what everybody's spending their time on Hope is, did we submit the documentation correctly? Did we do that secondary visit quickly enough? But figuring out the outcomes of all that's going to be super interesting. And I think there's a lot of work that you and I and the rest of our teams can be doing between Maxwell TEC and your companies and all that to help these agencies with where are they with Hope? Are they getting better or worse? Or is responding the only thing we need to do, and getting the visits submitted the most important thing, or is it taking care of the patient? And you and I both believe taking care of the patient's the right thing. Where do you see virtual care or remote virtual visits in the future? I mean, do you see that? And let's talk hospice and home health, because I think they're different.
So I think the regulatory environment is the first thing for everything to get sorted out. It's what's allowed, who's allowed to do what, when are they allowed to do it. One of the biggest things that we talk to our partners about is the ability from a conditions of participation perspective, or from any other CMS requirements. Are you able to do virtual visits as a non-employee of the hospice or home health agency? So I think that's kind of the first thing that we would be looking for a little bit of clarity on. However, just overall, I mean, I have to imagine that if we're not utilizing as an industry virtual visits a bit more tactically, we're missing a huge opportunity to get some of that efficiency that we talked about earlier. So on hospice as an example, the ability to be with the patient in the home virtually it's not as good as a nurse being there, but it's probably second best thing. It's probably even better than that phone call. The question is, can you do that? Who can do that? When can you do that? How does it count towards supporting the patient? There's always going to be, right, the primary thing that our industry has to continue to focus on is that care in the home. I mean, we need to be able to provide care in the home. And so you don't want to lose that, but we also have to evolve on the care model and getting that efficiency. Otherwise, it's going to be really hard to remain profitable and have enough providers to service the demand that's going to be there over the next decade. On the home health side, I think it's a lot more there's a lot more flexibility in how you can do that, and I would see that evolving fairly rapidly. I think us and a lot of other vendors in the space are already kind of thinking about whether it's video visits in the home, whether it's thinking about remote patient monitoring, how do you deliver that more effectively. I think home health, there's a lot more opportunity to really focus on the outcome of reducing the rehospitalization risk, improving the outcome, really driving that forward from a virtual visit perspective. So I think utilization will increase, and it'll be quicker in home health than hospice, but would love to see it also be utilized in hospice at a more intense rate.
Yeah, I agree. And I, just checking on Nana every day. And I mean, why does it have to be an or? Why can't it be an and? I expect you to do 10 in-person visits and 10 virtual visits. So Nana's getting, 20 touches, or 20, interactions with the agency. And today people are doing that. It's so not cost effective because it's not reimbursed. So it's hard to do it. But I mean, it's expensive to pick up a car and head to a patient's house. I mean, if you can just pick up the phone and do a visit, why not? And answer a lot of the questions and make sure the patient's taking their meds and doing those kind of things. So I'm a huge fan of it. I think that the government should figure out how to start reimbursing for it. Let's talk about AI. Everybody's talking about AI. I just looked at the Homecare 100 book that came out. I don't know if you got it today or not. Every single advertisement's got AI. We're an AI company. We're an AI company. AI company. And being the guy that was the first kind of AI company in the industry that when we started building Muse back in the day, I understand why everybody's talking about it now. But it is, I mean, literally that's on every single advertising page. It's AI. Somebody's doing something with AI. And so let's go hard. Daniel, you're a smart guy. You went to Harvard. You're a Navy submarine. What the heck is AI? And let's talk about it.
Yeah, so I will preface this entire conversation with I'm less bullish on AI than most people. There's a very real role for it, and the future of it is certainly bright. But it's for me, it's a little bit overhyped at the moment. As far as we get to just the core of like, what AI is, I think there's a variety of ways that people think about this. It can be as basic. I hate to say basic, but as basic as kind of the predictive analytics for machine learning that has been happening for years, as you noted with Muse. Like that's where all this starts to all the way to like agentic AI and having a bot be able to digest a medical record and then take some action on it as well. So there's a really wide spectrum on what can happen in AI. I think for us, and I'll just speak for IntellaTriage, we looking at it as a complement to the care. How do we provide how do we utilize it to provide really efficient care? How do we help our productivity so we can see more patients or help more patients and do it better, as well as helping support our nursing team in real time to hey, here's some things to be thinking about when you triage a call. There's a lot of things you got to be doing. So sometimes it's just having an AI agent say, hey, just this sounds like a pain call. Think about these few things, and those are the kinds of things we're working on, and how we're kind of planning on implementing AI in our business. But we're probably one of the very few that does not mention AI in their advertisement. But we're very firmly kind of our motto is like, hey, we're nurse first. We want to help improve the lives of nurses and patients, but it's not. We want to enable through technology, but it's not we're not a technology company.
It's super interesting to me like how everybody's talking about AI. And what is AI? Right? Is it clinical intelligence? Is it artificial intelligence? And I don't like the word artificial intelligence. I don't think it's artificial. I think we're training. If it's a large language model, and for the audience, that's we train the data around what's the next words in projection or prediction. So if I say Nana has congestive heart failure, then it's going to continue down that path. And so that's what a large language model is. The neural nets, being able to take data and give it a score and all those kind of things, like what Muse does to be able to predict hospitalizations there. I do think there's clinical intelligence to make mundane tasks that we're doing a lot easier. So how do I summarize a medical record for you? How do I look at medications and say, if Nana's on this medication, if she's on Coumadin, she needs a PT&R every 2 weeks. If she's on this medication and she has a drug-to-drug interaction to this medication, we need to think about what that's going to do and what the disease process. So I think it can make us smarter and better. I think we can use it to predict things. I think we can predict falls with it. I think we can predict medication errors. We can predict strokes. We can predict sepsis is a big one that all the hospitals are trying to figure out how to, keep Nana from getting septic, because that's what puts patients into a real crisis situation. So, we can look at things like that and use computers to alert us. And so all that's available to us now, but I mean, let's use it in a positive way and use it to influence the industry. And what should people be scared about as they're thinking about, if I'm a CEO of a home health or hospice agency and my team's coming to me saying, hey, we want to do documentation faster. We want to do ambient listening. We want to, we want all this stuff in the home. Like, what should we be scared of there?
Yeah, I mean, to me, it's still focusing on helping enable care versus actual care itself, right? Like that to me is when it starts bordering on providing care, and I don't mean hands-on, but really, we being in a kind of a telephone call center type of business, I'm always kind of trying to keep up to date on what the latest call center technology is. And there's a lot of AI agents now that have we can triage your call, or we can do this, and the industry's going to get there, right? It's going to be good enough to do that at some point, but we're not quite there yet. So that kind of tends to be my measure of risk is how do we enable better clinical decision support, quicker documentation, more accurate documentation, summarization of a chart so you get the insights you need. How do we help enable the nurses or the clinicians to do their job better? That's where I would be focusing if I was running a home health or hospice. Where I would be still skeptical is, this is determining the interactions that we have with the patient, or this is determining the plan of care modifications we're going to make for this patient. That's where I would still continue to be a bit cautious.
If you look at your model, like you have a giant call center with people scattered probably all over the place, plus a call center, and so the phone's ringing. I know the phone number that's calling me, always do, right? That's old school technology, but then I could steer that phone call to the right nurse that has the license to manage that right patient, to make sure that I have that chart pulled up in that EMR or in my technology to make that interaction faster. So, and by the way, I wrote one of those EMRs, so it takes a little bit to go look up. If you want to look up Betty Smith, there's 900 Betty Smiths, and I got to find the one with this date of birth. And technology could do all that for us really quickly. So why not? Right. So let's use it for that. That's not changing. But I just sped up that call. I made Nana, answer on the first ring. I made Nana wait, 2 seconds versus 2 minutes for me to pull up her chart and read her chart. I can think about what she's asking me and say, okay, I need medications. Click, boom, here's all the meds. Boom, here's, plan of care. Here's the schedule. Here's the visits. Maybe probably one of your number one calls is, when is my nurse going to be here? Yeah, she's coming tomorrow. I promise you. We've already solved that with some other technologies, but yeah. And so I use AI to the tools the way it was designed. I'm not saying we have to go in there and put your finger in the butt in in a hole in the wall and it comes back and tells you have whatever cancer and diabetes and all that. That's not AI in my opinion. So I think there's a lot of cool tools out there, and especially in the call center world. I mean, there's real professionals. Ritz-Carlton, AT&T, Apple, all these guys are using unbelievable technologies to steer calls and do the right things. I'm sure you get inundated with people calling you on that. So I agree with you. I think when I think about a home health and a hospice provider is, how can I make that computer operator mundane job faster, easier, better? If it's scanning orders in and dropping it into a medical record, that's a terrible job, right? You scan an order in, you get an electronic order. Now you got to go verify the order was signed by the doctor. You got to make sure his, all that kind of stuff that like Procura does. I mean, to me, that's an easy job. Like, let's make those things go away first. Processing workflow. Lots of workflows don't need to be processed. I have a non-visit time request. I have a visit documented outside of the visit. I mean, I can verify you were in the home. We did the visit. Why do I need to spend time clicking buttons? Processing payroll. I can verify when your visits were. So a lot of that kind of computer operator type work, I think AI can help us solve that. But, when it comes down to true clinical, I always call it hugging the patient. When it comes down to hugging the patient in the home, I don't care what kind of robot you have. It's not going to fix it. AI is not going to be there for a long time. So I don't worry about that kind of stuff.
Yeah, I think that's one of the things that we, all the use cases you just talked about are how we think about it. How do you, enable faster, better, more efficient care? And then, the role of the clinician really becomes that, one, the clinical expertise, but also the emotional support. Like that oftentimes is very overlooked whenever it comes to just what is needed, especially on hospice. I will say it's just the emotional support for the family, that you're doing a good job. Like that's the piece that you get hugging the patient, hugging the family. That's where you really try to, differentiate of having that empathy and compassion for the family and what they're going through.
Yeah. Have you ever been to CES, the Computer Electronics Show?
One time when I was in business school. Yeah, one time.
Oh, you did? Yeah. So I used to go all the time. Samsung used to pay when I was at Homecare Homebase. Used to pay me to go to that, and I would speak for them at the conference. But it was always fun. It's crazy, like all the cool technology. So I was watching a bunch of videos on CES, and everybody knows I'm a podcast junkie. I really don't listen to music when I work out, but I was listening to them this morning. They were talking about all the robots and stuff, and LG came out with a robot that completely does laundry. Samsung has one that does laundry, does dishes, it loads the dishwasher. Like, I can't wait for that. Of course, my wife's like, hell no, we're not putting a robot in this house. He's not going to listen to everything we talk about and all that. But there's got to be a way to control all those kind of things. But I mean, I can't wait for that, right? Like those tasks that, first of all, I don't do my own laundry. I can't stand it. Jennifer doesn't do it either. We have somebody that does it, but why not have a robot? When you take your shirt off, it goes and folds it and cleans it and puts it away. And tomorrow that shirt's there ready for you. I mean, we wouldn't have to buy near as many clothes. And I don't know. I'm excited about that part of AI and the world of robots and robotics. It scares me a little bit more that it's going to try to take over, certain jobs and certain roles. And I'm not a freak out about it. But yeah, it's good. That's a good discussion though. Let's start talking a little bit about when you hear the last visit first phrase. What does that mean to you? And why do you think we named this podcast Last Visit First?
Yeah, I mean, I'll tell you, as soon as you came out with this, you started seeing things on LinkedIn and started seeing some of your posts on Last Visit First. I immediately related it back to my dad, right? And we did not have the best hospice experience possible because it was so short, right? It was a day and a half. By the time you get, and when you have end-stage renal disease, by the time you're going on hospice, it's basically how long's it been since your last dialysis treatment, and then you have a finite amount of time.
Terrible. Sorry, man. I'm sorry, brother. That's terrible. You got caught in the monotony of our government, which is unfortunate.
But I mean, it really does color like my viewpoint on how I think about both our business and the industry, which is, if you could design what that last interaction for my father was, you wouldn't have designed the system as it was. So to me, that's, it's thinking about, hey, how do you want this to, especially on hospice, how do you want this to end? Let's design the system with that in mind. Let's keep the last visit and, put that first as we go through and design what the care looks like. Definitely home health as well. But that to me is kind of what just jumped out when I read. I don't know if that's what you intend or not, but that's what jumped out to me when I read the title initially.
Yeah, and then when we were trying to name it, Cole and I spent a lot of time working on names of the podcast and all that. Last Visit First jumped out because we were trying to make that last visit the same as the first visit. So when we start treating someone and they start going into this hospice and home health, how do we treat them like this is the last time we're going to see them, or the last visit, and make sure we're solving all their needs, taking care of them emotionally, spiritually, physically, through medications, all those things. So how do we make that last visit just like the first visit?
In home health and hospice, growth isn't just about closing deals. It's about execution. I'm Jay Duty, Chief Operating Officer at Maxwell TEC. We work with operators and investors navigating mergers, acquisitions, and rapid growth. And we consistently see the same challenge. The deal closes, but the organization struggles to perform the way it had. That's where Maxwell TEC delivers. We specialize in post-acute M&A optimization, standardizing clinical and operational forms, redesigning care pathways, aligning workflows across disciplines, and leading enterprise implementations from planning to execution. Our consulting is focused on throughput, productivity, compliance, and technology adoption. So organizations don't just integrate on paper, they operate as one scalable platform. This is not slide deck consulting, it's operational execution. We help organizations reduce documentation variation, improve their throughput, and ensure clinical, operational, and technology strategies are all aligned, especially in today's environment of reimbursement pressure and regulatory scrutiny. If you're integrating, scaling, or preparing for your next phase of growth, we'd welcome a conversation. Visit maxwelltech.com or email sales@maxwelltech.com. From first touch to last visit, this is how organizations scale with confidence.
What else are you guys working on in IntellaTriage? Let's talk about that. Where's the future taking you? I mean, I know you're trying to grow your business. I know you're continuing to, bring on more and more customers. You have quite a few competitors that are coming in. Where are you guys headed? What's the next steps?
Yeah, I mean, I think we've been very fortunate in the last 6 years. We've grown way more than I could have ever imagined. We've 15x the business at this point from a top line from when we bought it in 2019, and I think that really highlights more the demand for consistent quality care than anything. To us, I think our biggest asset is our nursing team. We consider ourselves a nursing company. We're a vendor, but we consider ourselves a nursing company. And so as we think about the future of our business, it's about how do we continue to help our partners and others in an industry, with these clinical services that it's really tough to hire and maintain a workforce for. So that could be anything. Again, so we've started expanding into care team coordination. Where we have a patient engagement service that is not, it's not the tech portion. We're not a tech company, so there's a lot of great companies, and Connect included, that have this really great tech, engagement model. But then inserting clinicians into the loop. Right now, that usually falls on the provider. So having IntellaTriage start playing a little bit more in that role and being the clinician that helps with that. I think we just see a ton of areas to have kind of outsourced clinical services that allow the providers and operators to operate a bit more efficiency and a bit more at scale, which then again will help with that margin compression. I'm acutely aware of how much pressure the providers are going through right now, both from top line reimbursement and kind of all your bottom line expenses growing at a rate it's just not sustainable. So we're trying to insert ourselves into that cycle so we can help provide a bit more scale and efficiency. Outside of that, I think the tech piece is a big part of our strategy going forward. We've always been, I would call ourselves, a quietly innovative company. We built an IntellaHub, our platform, that's our triage platform that our nurses and our customers use. So we're coming out with more and more enhancements and more modules on that. Again, I don't think we'll ever be considered a tech company, but how do we continue to layer in technology to really enable great quality, consistent care 24/7? That's a big part of our strategy going forward. So it's going to be partnering with really high quality tech companies, or building a little bit of it ourselves. But that's a big part of where we want to go as well.
And you're based in Nashville, right? Is the entire leadership team in Nashville?
Yep, headquarters here in just south of Nashville and Brentwood. Our entire leadership team, with the exception of some of our sales leaders, and our VP of marketing, is here in Nashville.
Yeah, I love Nashville. It's what a fun town. I go there for Metalogics or Mosaic board meetings a lot, and so spent a lot of time there. Spent 6-8 months there when we sold Muse to Mosaic and or Metalogics, and love that town. It's growing like crazy. Your Titans suck, but
They're not good.
so do my Cowboys. Though, by the way, they're terrible.
You guys at least have more hope. You know, you got a great quarterback, good receiver. Yeah. You're building a base.
I don't know. I heard a comment the other day that Jerry Jones wants 3 more Super Bowls because he wants to be known as the owner that has the most Super Bowls. So he wants 3 more Super Bowls before he dies. And I'm like, there's not a chance, man. Like, I bet let's get to the playoffs 3 more times before you go. Let's make it easy. Jeez, what a terrible. I mean, it's been a good football year, though. The college games have been amazing this year. So it's been a lot of fun to watch it. So you tell us about you personally. You, when I chat GPT'd and Perplexity, you tells me you're a DIY guy, like you like doing home projects and things like that. Tell me about that. Like, what's the story there? And it also said you're a runner, so that's how you stay in phenomenal shape, is running. Is that what it is?
Yeah, I would say that the information is a little outdated now that I have kids. I do a lot less DIY projects. I still like to do my fair share around the house, especially outside. Still love to run. I'm actually training for a marathon right now. So all it's probably true, but you know, I've been married. I got married very early. I got married at 21. My wife got married right out of college. You know, we always say it was the best mistake we ever made. Right? It was just phenomenal that we got so lucky. But we have two girls now, a 7.5-year-old and a 2.5-year-old. So are growing up way too quick, especially the 7.5-year-old.
Right.
So most of my free time, you know, I kind of subscribe to the philosophy like my work life and personal life are very blended. I don't have a ton of separation. I know that doesn't work for everyone, but for me, that's, you know, how I grew up in the family business, seeing that was work and you know, life just kind of was one. So whenever I'm not working, my girls are where I spend, you know, 90% of my time squeezing a run, you know, 3 or 4 times a week. But for the most part, just love hanging out with them and seeing them grow up.
You're training for a marathon again? You're too old for marathons, man. Like, come on.
I have a ridiculous goal to complete an Ironman at some point in my life, and I'm not getting any younger. So I figure you train for a marathon, that'll be the first step, and then who knows what happens from there. So
I don't know. There's a guy, I listen to Rogan's podcast a lot. There's a guy on there, I can't remember his name, but he's done like these 200-mile races multiple times. I mean, he's got knee on, you know, bone on his knees, but the guy's just, I mean, it's a beast. He's just a beast at you know, running. It's something I don't, it hurts my butt to ride in a car for a marathon. Can't imagine running a marathon, but no, I'm the opposite. I go to the gym every day, work out, but I do not like running, but I respect all you guys that do, right? That's awesome.
Bernadette Smith, our VP of marketing, she's one of those ultra. She did a 75-miler the other day. You know, it's like right before the holiday, she did a 75-miler over 24 hours. It's I can't imagine. That's just wild. But yeah,
holy cow. That is cool. That's really cool. Let's talk about burnout a little bit, since we're talking about marathons and ultra marathons and that kind of stuff. How do you keep, where do you think our industry is headed towards burnout, and how do we keep people from burning out? And is there any tricks that you have that you can share with the audience around, you know, what you guys have done from a benefits package? Or, I mean, you've got all these people that stick around with you for a long time and they love their job. I mean, great. It's a great environment. You're not having to get in a car and go into anybody's home, but like, what do we do with burnout? And like, it's something I'm real worried about. I spent a lot of time thinking about it.
You know, I talked about our recruiting pipeline earlier. I do think that is some, you know, leading indicator on burnout in the industry, right? The most common response we get to, like, hey, why do you want this job, is I need a break from the field. I need a break from the, you know, the expectations and the load that comes with being a clinician in the field every day. So I think we see it firsthand from the employees that are coming to us. They are in some ways looking for a little bit more of a reprieve versus what they're getting in the field and the care burnout that they're feeling. So very real, a problem that I would say we are only seeing grow versus, you know, get better. I wish there was a secret sauce to it, right? I mean, I'll say that, you know, figuring out the pain points for your team and trying to address them in a real way is where we've seen people have a lot of success. You know, we have a Common Spirit Health at Home's a partner of ours, and that we have a, you know, kind of a couple of case studies with them around how they thought about burnout in the middle of the pandemic. And that was a big reason they outsourced their triage function to try to remove as much of that burden from their team as possible. And they did see some really positive results from it. But I think that's, you talk to your employees, any employee survey for clinicians is going to say, hey, I hate charting, I don't like my pay, and I don't like on call. And so, trying to address some combination of that, I think is really important to improving burnout. I also say just like documentation seems to be the one that, me personally, not having a ton of experience in the industry, coming into the industry, it's insane how much documentation has to happen just to provide care. Like it's a ton. And so I think as we get tech that can help with that and help improve those processes, you don't usually see a regression in documentation from a regulatory perspective. So, the more efficient ways to do that, I think will be really beneficial to those clinicians in the field so they can focus on providing care. That's what they want to do. They want to provide care. They don't want to chart for 45 minutes.
Yeah, I spent, my whole career since 2005 when I was in the practice management EMR business, which is totally different documentation, order sets, CPOE, computer physician order entry, all that stuff. Come over to home health, and I've seen it absolutely change. I mean, since 2005, think about the amount of documentation, and I mean, we were on Oasis B1 back then, and now it's just changed and changed and changed, getting harder and harder, more scrutinized. And you need a face-to-face and a CTI and and notice of admission. And you start talking about that. I mean, let's just talk about that for a second. So a notice of admission in home health, the government says you have 10 days to complete your Oasis. So I need a nurse to go out and do a thorough job on a starter care visit. I need you to spend as much time as you can on that visit because that's the one that I get scrutinized with. It's the one that we get paid off of. So answering the Oasis correctly, making sure the questions are right, making sure we have the supporting justification for the homebound status, which, again, I think the government should change at some point. And then, so getting all that right, but you have 5 days to do that. If you don't do it within 5 days, I start penalizing you and you're taking away money. So you've asked me to do the best possible job on the hardest visit possible as a nurse. And then in 5 days, if I don't complete it, you're going to take away my money. So now I'm asking you to go do it in rush. And so I want you to do your documentation in the home, but I want it to be thorough. I want it to be complete. I want to make sure that you have every disease process documented. I want you, every scratch, wound, abrasion, rash, all that stuff needs to be covered. But I want you to do it in 5 days. And if you don't do it in 5 days, I'm going to penalize you at the agency. And then I'm going to scrutinize you. And then I'm a surveyor. And I'm going to come look at that visit. And I'm going to compare that visit to what you did on the rest of the visits. I mean, it's literally like turning your paperwork in and letting 10 people grade your test and, what you did in my opinion. And so you think about that, like I'm a hospice nurse or I'm a home health nurse. There's a lot of pressure on a starter care visit. And then you got all these people that are going to review it in the back office, which is slow and takes a long time, just so that we can get it to the government to say, hey, we are going to take this patient on service and here's what we're going to do for them. And by the way, we can't do anything without a doctor's order. I can't change a supply. I can't change a medication. I can't change a visit frequency. I have to go get a doctor's order to do that. And so why is it hard to do home health and hospice? I mean, I just explained it right there. It's tough. And sure, we all built EMRs. I mean, I spent all my career trying to make that easier, how to make it faster, better, quicker. It's tough. It's a tough job. And so if I don't complete my documentation as an ICU nurse, they call me right back in and I get to do it in home health or hospice. I go see the patients as much as I can, get as much done in the home as I can, and then I go home at night and chart. That's not fun either. And so we're trying to make it faster, easier, better for you to not have to go home and chart. Tracy Den over at Accent Care calls it pajama charting. I love that. And it's the name. She calls it pajama charting. But we got to figure it out. We got to solve it in the industry. There's guys like Steno and, Ollie, all these other guys that are out there that are all trying to solve this. And I know they're working fast and hard on it, but we got to figure out how to give these nurses and therapists and chaplains and social workers and all these, give them their time back and let them do their documentation, but make it easier, quicker, faster, better for them.
Yeah, I think, I sometimes I miss the mark of my analogy to my team because I tend to think in military analogies. And I go back to, there's a lot of similarities between healthcare workforce and military workforce in that. It's more than just like a job. People tend to, it's not always the case, but people really tend to, they're drawn to this. They want this. They want to be caring for patients. That's why they came into this. And just like if you're on a submarine, you want to be doing cool submarine missions. Nothing will kill the morale of a submarine like maintenance, right? Like, oh, hey guys, for the next 3 weeks, all you're doing is documenting the maintenance. That's what your job is. That's what kills the morale. And that's to me is a little bit what's going on in home health is, that we're doing the maintenance. It's the charts, it's the documentation, and you're missing a lot of that care in the home. So I think to the extent we can, as an industry, and there are some great companies that are really focused on delivering this, really minimize the effort it takes to get everything documented appropriately so they can focus on that care. That care quality is going to increase.
For sure. And we got to do more. I mean, we have more patients coming to us than we could treat. And we have different payers, more payers coming. I mean, just the intake process. If you just think about the intake process when pre-COVID versus post-COVID, we used to go out, sales rep would get a few documents from the doctor's office. He'd get an order. He'd get the order signed. He'd send it over. He'd probably go to the fax machine, fax it in. They'd pick it up off the fax machine, type it into Homecare Homebase or type it into WellSky or NetSmart, and away we would go. And now they all come electronically. There's, 100 pages of documents that come along with it. It goes to 6 or 7 or 8 different providers. Now we're all hustling to try to figure out who's going to go first. It's just like crazy. Just intake alone, you got to check eligibility, you got to check odds, you got to get a face-to-face, you got to get a CTI. You're like, what? I mean, it's like it's a checklist, like a pilot, like we're getting ready to take off an airplane just to figure out if I get to take you on service or not. And so it's kind of a lot harder. So, for those of you that are listening out there that are in the business deep, I understand, and we all understand. We're trying to solve it with technology. Guys like Daniel, myself, other companies that we're involved in are all trying to figure out how to make this faster, quicker, better. And we realize that the pain and the struggles of it. All right. Last question. We got to wrap up here, my friend. When your career is eventually done, when IntellaTriage is either you sold it and you made a whole bunch of money or the next guy's taking over and you're riding off into the sunset to, hang out at kids' graduations and hopefully be a granddad and be a great granddad. What do you want your legacy to be?
So it's a great question. I will say I am young enough where I don't think a ton about this. A lot of what I'm thinking about is just how do we do it a little better. That's probably what I would want people to think about as a legacy is that we did it. We continue to keep our mission and core values central to how we're delivering service. It's great to build a successful business, but it's only going to continue to be successful if you're delivering the value in the way that you want to deliver the value. So I think, it's just trying to do a little incrementally better every day, every year, every encounter. And, I would love for people, once whatever happens, we sell IntellaTriage or, the next CEO comes in, and would love for people just to say, hey, Daniel was most focused on getting the triage or getting the encounters correct and delivering good patient care. That would be the number one takeaway for me. Seeing what has happened since we acquired it in 2019 from when it was founded in 2008, just those two different time periods have been unbelievable to watch from just a bystander perspective, because Susie's vision, who was the founder, is really been coming to fruition, over the last 6 years. And I think it's that kind of, I hope someone thinks about me in that way. And the next stage is like, oh, what Daniel was envisioning is still how we're delivering today. That would be success for me.
And where's Susie today? Is she still part of the business, or?
She's a part owner of the business still. She's based in Chicago. She does a little side work here and there, and her and I touch base a few times a year. We still have a great relationship. But yeah, it's really good.
That's awesome. And you've grown to 15x, so I bet she's really proud of where you guys are today. That's awesome. Daniel, thank you for your service, my man. You're America's hero, and you're doing a great job in business. Really appreciate you coming on the Last Visit First, and appreciate you coming in today.
Yeah, thanks for having me, and appreciate your service as well, Tom. It's been great. Thanks for having me.
All right. Thank you, sir.